Oh yeah. Good morning, distinguished keynote speakers, respected speakers, poster presenters, honored delegates, and estimate participants join us from the world. It is a great honor and privilege to warmly welcome all of you to Emirates Pathology, Digital Pathology, Cancer Conference, and exhibition. On behalf of the organizers committee, I extend our sincere appreciation to each of you taking the time to be part of this significant global gathering. Today represent more than just the commencement of the conference. It marks the beginning of a dynamic and collaborative platform. Then knowledge, innovation, and expertise converge. This event embodies the true spirit of international collaboration, uh, uniting professionals from diverse fields, such as including pathology, digital diagnostics, cancer research, and broader healthcare disciplines. Together, we aim to share valuable insights, cutting-edge research, and practical advancement in pathology, digital pathology, and cancer care will contribute to improving diagnostic accuracy, um, enhancing patient outcomes, and shaping the future of prestige medicine. I'm a researcher in Clinical Moscow Scientific Center, Putova Maria, and it's my pleasure to serve as our chairperson for today. I look forward to an energy inspired and highly productive day today. I discuss a little bit about Ethereum Conference Gathering is a leading global platform dedicated to organize high quality professional meetings, conferences, workshops, and symposiums. With a strong focus of medical, clinical, healthcare, life science, and pharmaceutical fields. It effectively bridges the gap between academia and industry through innovation, collaboration, and excellence. With a global reach 24/7 support and a highly committed organizing team, UCG ensures that every event is impactful, well structured, and tailored to meet the evolving needs of the participants. On behalf of UCG, I extend my healthfelt gratitude to our organizing committee, distinguished speakers, and all participants who have contributed to making this gathering a success. Together, we are driving progress and shaping the future of healthcare. Ladies and gentlemen, our first speaker is Dr. Folinas Konstantinos, consultant medical oncologist in Air Force General Hospital from Greece. He will present it on renal carcinoma therapeutic, clear cells, renal cells carcinoma versus non-clear cell, and unclear and unborn struggle to include everyone. Please, Dr. Folinas.
Thank you very much. First of all, I would like to thank
We can hear you
the.
not very well. Sorry.
Can you hear me now?
Yeah, now it's okay.
Okay.
Thank you.
First of all, I would like to thank the organizing committee for the honorary acceptance of my oral presentation. Uh, Ms. Putova, for announcing my oral presentation. The title of the oral presentation is renal carcinoma therapeutics, clear cell RCC versus non-clear cell RCC, and unclear and even struggle to include everyone. Kidney cancer is the sixth most common uh, neoplasm in the male sex and the ninth in the female sex. The happy survival rates is 93% almost in the local setting, 75% regionally, and 80% in stage 4. As far as the risk factors are concerned, we have to mention tobacco use, chronic use of acetaminophen and NSAIDs, kidney disease, chronic kidney disease, acquired cystic disease, obesity or excessive body weight, hypertension, chronic exposure to cadmium, asbestos, and trichloroethylene, and also genetic condition and family history when the patient is less than 45 years old. As far as staging is concerned, the first two stages are related to the tumor size. The stage 3 is related to the infiltration of the gerous fascia, and stage 4, the infiltration of the vena cava. But the renal tumors are termigenous carcinoma, with 70% of renal tumors being renal cell carcinoma, and of them, 70% being clear cell renal cell carcinoma. But this heterogeneity is not only reflected in that pie chart, but also in WHO classification, where WHO subcategorizes renal carcinomas in clear cell renal tumors, papillary renal tumors, oncocytic and chromophobe renal tumors, collecting duct tumors or other renal tumors that include a diverse set of renal tumors that do not fit in any of other categories. And if we see everyone, there we have to count more than 20 histologies, different histologies. And now, in the era of personalized medicine, we have to mention also the molecularly defined renal carcinomas that reflect recent discoveries in neurotumor genomics. And these histological subtypes uh, are the location, the cell origin of RCC are reflecting the histological subtypes. And also, uh, the therapeutic algorithm is not so unified, because in the oncological guidelines, there are two categories with clear cell histology, non-clear cell histology, and it seems like there are more options during the therapeutic path in the clear cell histology subcategory, and also in the and also we have patients being subcategorized based on prognostic factors to prognostic risk groups that guide us through first line therapy, and we see many molecules and the combination of molecules being suggested for our patients, whether they are unfavorable risk group or poor intermediate group. And we see also um, all the choice we have in the subsequent therapy for clear cell histology. But when we see non-clear cell histology,
Excuse me. Excuse
yes,
me. Dr. Falinas, we can see only your first, visible only your first page. Is it okay? Your presentation?
I will stop sharing and share it again.
Okay. Thank you.
Is it okay now?
Now it's okay, thank you.
Okay. Uh, but as we see the systemic therapy that is suggested in non-clear cell histology, we see that that the first preferred therapy is clinical trial, and after that we see cabozantinib monotherapy, cabozantinib plus nivolumab combination, and lenvatinib plus pembrolizumab, and not some other options that we saw in clear cell histology. And let's see some of the trials that gave us those choices in the non-clear cell histology subcategory. We have a phase 2 trial about patients with advanced or metastatic non-clear cell RCC that could have taken at most a prior line of systemic therapy, being assigned to receive cabozantinib 40 milligrams per dose daily, or nivolumab either Q2 weeks or Q4 weeks, with the endpoint being objective response rate, the secondary endpoints being progression-free survival or PFS, overall survival or OS, and safety. We see here that from 40 patients, the 32 were of papillary histology, 6 of unclassified without papillary features, and 2 with truncation slash associated. And they were subcategorized, even if we don't do that in everyday clinical practice. They were classified, they were subcategorized to risk groups via IMDC risk classification or MCKCC risk classification. And as far as objective response rate was concerned, when given this combination, when given in the first line, the ORR was 54%, and the second line was 36%, which was we expected that. And across the histologies was almost 50%, and a median PFS of 13 months. As far as the adverse events were concerned, of the 40%, 35% of the 40 patients, 35 patients had a grade 3 and 4 adverse events. From them, the 22 had a grade 3 or 4 rise of the hepatic enzymes, and the other experienced grade 3 and 4 hypertension and pain. 9 of them discontinued due to toxicity. And I have to mention that there was no statistical significant difference between the risk group classifications, meaning that in non-clear cell RCCs, every patient, besides this classification, derived the same benefit. As far as Keynote B61 trial is concerned, there was a histologically confirmed diagnosis of non-clear cell RCC, but they couldn't have taken a prior systemic therapy. They were assigned to pembrolizumab 400 milligram IV Q6 weeks for at most of 18 cycles, nearly 2 years, plus lenvatinib 20 milligram per dose with objective response rate as a primary endpoint and CBR, DCR, the duration of response, and PFS, OS, safety, and tolerability being the secondary endpoints. Of the 158%, 93 were of papillary histology, 29 of chromosome histology. 21 had unclassified histology, 6 they had translocation histology, and 9 had other histologies. So we see a bigger variety of histologies from the previous trial. And also they were subcategorized to favorable and intermediate and poor risk groups. And as far as OS was concerned, we see we had in the total population 13 CRs and 67 PRs, with the ORR being 50.6%. And in the papillary histology, we had 10 CRs and 40 PRs. The ORR in the total population was 49.4%. The response that was of any duration was 82.3%. The response of at least 6 months was 51.9%, with 9 CRs and 69 PRs in total. The reduction of tumor burden varied across the histologies, and the PFS was 17.9 months. The median PFS was 17.9 months, and OS was not reached. And there was no statistically significant difference between the risk groups. Now we come to SWOG 1050 study that accrued patients with papillary RCC that could have taken at most one line of therapy, but not sunitinib. There were 4 arms, and the patients were randomized to receive sunitinib, cabozantinib, crizotinib, savolitinib, with the primary endpoint being PFS, secondary endpoint being overall survival, response rate, adverse event, and exploratory evaluation of MET mutational status and MET expression. I have to mention here that a futility study was performed at the start of the accrual, and because the hazard ratio was more than 1 for crizotinib and savolitinib, the accrual was discontinued in these two, in crizotinib and savolitinib, but the accrual continued for sunitinib and cabozantinib. And the median PFS for cabozantinib was 9 months, and sunitinib was for sunitinib was 5.6. So with cabozantinib, we saw the PFS was prolonged. The OS was 20 months for cabozantinib versus 16.4 for sunitinib. In the arm of sunitinib, we had only 4 PRs, partial responses. For the arm of cabozantinib, we had 5 complete responses and 18 partial responses. The confirmed overall response rate with cabozantinib was 23%, significantly higher than with cabozantinib with 4%. I have to mention that there was no statistical significant difference between the risk groups. And as far as the adverse events were concerned, we saw 68% grade 3 or 4 in the sunitinib arm, 74% in the cabozantinib arm, 37% crizotinib arm, and 39% the savolitinib arm. And those were the trials that the studies that gave us all these choices in our guidelines. But I have to mention some other studies that gave us some promising but not so promising results with Sunny Forecast, the study that included patients with metastatic or locally advanced non-clear cell RCC. They couldn't have taken any systemic therapy previously for RCC. They were randomized to receive nivolumab plus ipilimumab for 4 times, followed by nivolumab Q2 weeks or Q4 weeks. Or on the other arm, they could have taken standard of care agents that the investigator were set until progression and unacceptable toxicity or withdrawal of consent. The primary endpoint was OS rate at 12%, at 12 months. Key secondary endpoints were OS rate at 6 and 18 months, PFS, objective response rate, safety and quality of life, and exploratory endpoints were predicted by biomarkers like PD-L1. There was no statistically significant difference in those arms as far as PFS was concerned. We saw that the overall survival was prolonged from 33.2 to 25.4 in the first arm to the second arm. And as far as the objective response rate was concerned, the nivolumab plus ipilimumab arm was at 32.2, and the standard of care arm was at 19.8. And also, we had Calypso phase 2 study investigating savolitinib in combination with durvalumab in advanced papillary renal cancer. Uh, it was only about papillary patients with papillary renal cancer. They should have been VEGF naive or treatment refractory. And the combination was given until progression or loss of clinical benefit. And the most important thing was that they were ctDNA was tested baseline week 4 to 16, and at progression of disease, and we saw that the intention to treat population PFS was 6.5 months. The intention to treat population overall survival was 18.3 months. The med-driven progression-free survival was 30.9 months versus 2.9 months with a hazard ratio of 0.25. In the med-driven overall survival, we had the med-driven OS being at 27.4 months and not med-driven population at 12.3 months with hazard ratio of 0.73, with a median duration of response at 11.3 months. There was an exploratory analysis according to PD-L1 and TMB status that showed that TMB and PD-L1 did not correlate with either PFS or OS or another endpoint. But the most important thing was that the ctDNA positivity at baseline was correlated with shorter OS. That was a very the most important messages. One of the most important messages of this trial. But we have to say that the therapeutic pathway of non-cell RCC looks brighter with many ongoing and non-clear cell RCC clinical trials with novel therapies or novel combination of therapies with the use also with certain biomarkers. But also I have to mention that many molecularly defined renal carcinomas are included in those trials, such as TFE rearranged, FH deficient, SD deficient, or ALK rearranged tumors. When in these trials, many targeted therapies plus and immune checkpoint inhibitors are being evaluated in these rare subtypes. And I have to if I would mention one or two of them, I would mention NCT 050, 43, 090 with papillary RCC metastatic that for a MET-driven population with 3 arms. Well, the first arm will be savolitinib plus durvalumab versus sunitinib versus durvalumab monotherapy until treatment progression. And PANCBET-2 trial, metastatic papillary renal cell carcinoma. It says here with either type or 2 carcinoma, because with an older WHO classification. And the patient will be randomized to receive 2-to-1 cabozantinib plus atezolizumab versus cabozantinib until progression. Thank you very much.
Thank you, Dr. Falinas. Anyone have any question? Okay, can I ask you a little question?
Yes.
Why is treatment developed more advanced uh, for clear cells carcinoma compared to non-clear cells carcinoma?
Could you please repeat the question?
And now, do you hear me okay?
Yes, yes, yes.
Okay. Why is treatment developed more advanced for clear cells carcinoma compared to non-clear cells renal carcinoma?
The fact that we have more combination, more novel therapies, is that clear cell renal cell carcinoma is 50% of all renal cell carcinomas, and all other histologies are other than the papillary are very rare subtypes. And if you see non-clear cell RCC clinical trials are mostly for papillary carcinomas. I would say that for someone that designs a study about renal cancer, it would be better uh, to design it about a subcategory that is the most often, and it can accrue more patients. But we have to find ways to foster and the patients from the other subtypes. And now that we have many more tools and many biomarkers to personalize and tailor the treatment and tailor via biomarkers and the studies, and make
Okay.
studies that would categorize these rare subtypes with many biomarkers.
Okay, good. Thank you. Thank you, Dr. Falinas. And our next speaker, um, Dr. Voda Fatima, oral pathology resident at Zlautin University, who joined us from Pakistan. She will present at Can Salva replace tissue, the role of liquid biopsy, and AR in oral oncology. Very interesting topic. Please, Dr. Fatima.
Assalamu alaikum, everyone. Am I audible?
Yes, we see your screen.
If any, can you see my screen? Am I audible?
Yes, yes, Dr. Fatima. Thank you.
Okay, so shall I begin? Okay, assalamu alaikum, everyone, and good morning. I'm Dr. Varda. I'm an MDS resident in the Department of Oral and Maxillofacial Pathology at Ziauddin University, Pakistan. I would like to begin by sincerely thanking all of you, the organizers, and to all of the respected faculty, members, and the attendees for being here. It is truly an honor to share this platform with such distinguished audiences. So let's begin the discourse, I believe. So the topic is that can saliva replace tissue? The role of liquid biopsy and artificial intelligence in oral oncology. Now, I don't know why the slide is not going further. Okay, yeah. So now these are the topics that we're going to cover today, which is going to be a little bit of background, the paradox of tissue biopsy, liquid biopsy, biopsy as a conceptual shift the diagnostic potential of saliva and integrating that information into AI. Now, globally, oral cancer does represent a major public health burden with over 300 million new cases annually and disproportionately high mortality rate, particularly in South Asian countries. And now this report is by the Globocan IARC of 2022. Now, large-scale analysis does demonstrate that delayed diagnosis remained the most critical determinant of mortality due to oral cancer. And despite the advances in oral oncology, still early detection strategies, they are inadequate. So today, there's a dire need for early detection, non-invasive tools, and tools that have a major scalability approach, especially for low middle income countries. Now, we are all well aware that tissue biopsy, it remains a gold standard to pursue a definitive diagnosis. Nonetheless, it is invasive and heavily operator dependent and technique specific. Now, hence, biopsies cannot be incorporated as screening tools. However, tissue biopsy is a definitive diagnostic tool. It does provide us with a static, localized snapshot of the disease, but it still fails to capture the tumor heterogeneity and temporal evaluation. Now, this creates a diagnostic gap between the detection and the monitoring process. Now, to be able to bridge the gap, there are emergence of several conservative techniques, and one of which is liquid biopsy. Now, liquid biopsy represents a paradigm shift from a static diagnosis to a dynamic one, and it enables a real-time disease monitoring and early detection. Now, it is particularly valuable, especially in cancers like oral squamous cell carcinoma, where accessible biofluids already exist, like saliva. Now, the concept of liquid biopsy is not only specific to saliva. Now, liquid biopsy means extracting body fluids and then extracting all the information that's present in that body fluid and studying that information to create a clinically relevant answer, right? So, biological body fluids that can be used in liquid biopsy includes saliva, urine, blood, and breast milk. Now, the applications where they're used today are epigenetic changes, mutational profiling, personalized treatment, therapeutic resistance, tumor subtyping, and genomic mapping. Now, the question still arises that can saliva act as a diagnostic alternative or not? So, saliva itself is not merely a secretion. Rather, it is a biologically active diagnostic medium, or you can also call it a biofluid. Now, it contains an array of molecules which include nucleic acids, proteins, metabolites, and microbiota that reflects not only your local disease state, but also your systemic disease state. Today, the advances in omic technology have demonstrated that saliva mirrors tumor-associated molecular alterations quite well. Now, saliva itself is a quite non-invasive, easily accessible, cost-effective biofluid, which quietly reflects your local oral environment as well as your complete systemic disease state. As I mentioned before, it does contain DNA, RNA, proteins, metabolites, and microbiome signatures. Now, these can include your interleukin 6 and 8, which are quite clinically relevant to showcase your inflammation, your tumor progression. CD44, protein that shows cell adhesion and metastasis, the microRNAs like microRNA 31 and 21 that showcases your gene regulation, and ctDNA, which is tumor specific mutation. Now, tumor derived signals, they reach saliva through multiple mechanisms. They can be through direct shedding from oral lesion, they can be through systemic circulation and the concept of transudation. They can be through exosomal transportation. Now, several studies have identified transcriptomic and proteomic signatures in saliva as well, which remain capable of even distinguishing cancer states. So, the objective of this entire review was to evaluate the diagnostic potential of salivary biomarkers, to explore the integration with artificial intelligence, and to actually compare against the conventional tissue biopsy. The methodology was a narrative review, and the databases utilized were PubMed and Google Scholar. Inclusion criteria was peer-reviewed studies and recent literature. Now, salivary biomarkers can be evaluated through key categories, which include your genomics, your transcriptomics, your proteomics, and your metabolomics. And as I mentioned before, the important biomarkers that we study are interleukin 6, 8, CD44, and microRNAs. Now, inflammation-driven biomarkers, they remain among the most validated ones when we're trying to explore OSCC. Now, interleukin 6 and 8 are consistently elevated in OSCC as they correlate with tumor burden. They also showcase an inflammatory disease state, like, for example, in periodontitis or gingivitis, they're also quite elevated, or in any other inflammatory state. But it is quite elevated in tumor state as well. Now, CD44 has been also implicated in tumor progression and cellular adhesion dynamics. Now, these markers, they reflect the tumor microenvironment rather than the just presence of the disease. Now, microRNAs, they provide a quite stable and a specific diagnostic signaling pathway. Now, salivary microRNAs, they have demonstrated discriminatory capacity between the OSCC and healthy controls in a study by Park et al. Now, a study by He et al. Showcased that exosomal microRNA of 24-3P has emerged as a promising biomarker for early detection of OSCC. Now, their stability in the biofluid makes them quite ideal for non-invasive diagnostics. Now, from evidence to multi-omic approach, now we know it quite well that a single biomarker will always remain insufficient for diagnosis. So multi-omic integration is the key. Now, meta-analytical evidence showcases that combined biomarker panels significantly improves diagnostic accuracy. Multi-marker liquid biopsy frameworks enhances both sensitivity and specificity. So hence, the diagnostic potential for saliva in the biomarker realm is that it showcases high sensitivity in early detection, correlation with tumor progression, and it remains of the disease. Now, all of this information, but with the lens of artificial intelligence. Now, the complexity of salivary data necessitates computational integration. Now, AI, it facilitates pattern recognition across highly dimensional biomarker data sets, which allows to generate some predictive models for diagnosis and prognosis. Now, AI transforms the biomarkers into clinically actionable insights. All of the information that we extracted through the saliva will now be integrated into the AI models, and we can then generate some clinically actionable insights. Now, machine learning models, they have demonstrated improved diagnostic performance compared to single marker approaches. As we integrate AI into multi-omic data, it enhances risk stratification and early detection. So AI's application with its machine learning and deep learning and its functions like pattern recognition, risk stratification, multi-marker integration, and predictive models, they remain quite significant when we integrate it with the salivary information that we have extracted. Now, combining AI with the salivary information will create a revolutionary model for the future. So when we combine this molecular data and computational analysis, the result is increased diagnostic accuracy and an opportunity for personalized treatment in oncology. So, as we integrate these biofluids like saliva, blood, urine, we extract the analytes like peptides, DNAs, and RNAs. They are then recognized through receptors and bioreceptors and then converted into electrical, biochemical, or electrical signals through transducers. And then the data is created into an output data via amplification, signaling processing, and data visualization. Now, all of this output is then fed into the AI systems, and then the AI's large learning models and deep learning models, they generate patterns for recognition and strong predictive modeling ahead. Now, the question still stands that where do we stand in the clinical realm, right? So, as revolutionary and exciting as it may seem, the key still remains that where are we in clinical translation, right? So, now the counter argument to this is let's explore that why saliva cannot replace the tissue. Saliva lacks defining elements of diagnosis, which is the architecture. Histopathology provides us with tumor grading, invasion patterns, and margin assessments, which are very relevant, which are gold standard. Now, liquid biopsy cannot currently replicate this. So multi-marker plus AI models, they do improve the predictive accuracy, of course. Saliva shows a strong diagnostic promise, yes, but study heterogeneity, lack of standardization, and limited multi-center validation still remains. Now, the question today would be repositioned to that it's not about replacement of the tissue biopsy. It's about integration. It's about monitoring. It's about prognosis. It's about prediction. Now, this aligns with the current consensus in liquid biopsy research as well. So, the future direction that we're headed is towards exosome based nanodiagnostics, AI integration, diagnostic platforms, point of care saliva testing systems, particularly impactful for resource constrained settings. Saliva can be used for early detection, risk stratification, and disease monitoring, yes, especially for resource constrained settings like Pakistan. But limitations, they still exist. Sample collection is there's a limitation in variability, like sample collection and assay techniques. We have lack of clinical standard protocols. There's a lot of AI-based challenges, which includes the data biases and need for large sets to accumulate significant and true data. So to conclude, saliva cannot replace tissue biopsy yet, but strong complementary role of saliva is quite evident. Thus, integrating this information with AI, standardization of the protocols, and multi-center validation will create a potential for saliva to become a validated screening tool. Thank you so much.
Thank you. Thank you, Dr. Voda Fatima. Does anyone have any question? Okay, I have a question. What role does artificial intelligence and analysis solve biomarkers?
Oh, sorry.
Uh,
Okay, so biomarkers, the information that that we extract through the biomarkers, right? That information, when converted into data sets, will be fed into the artificial intelligence. Now, artificial intelligence, with its deep learning and LLM models, will help us to create a prognostic data set and a predictive data set. Now, this will ensure such information that we can go for personalized treatment planning, we can go for screening models, monitoring prognosis. Now that's a vast realm that we can get from AI when we integrate this data into it.
Thank you. Can I ask you one more question?
Yes, surely.
How accurate and reliable are salivary diagnostics compared to traditional methods?
Can you repeat? Your voice is breaking.
Sorry. How accurate and reliable salivary diagnostics compared to traditional methods?
Okay, so traditional method is your biopsy, right? So as I said in my presentation as well, salivary diagnosis cannot replace your traditional methods. The only
What is it?
thing that saliva is doing is just providing a medium for, you can say, early diagnosis. So what we can do, just say, okay, so I have this idea that what we can do is, when a patient comes to you as in the OPD and we diagnose some potentially malignant lesion like an oral ulcer or a non-healing ulcer, right? Or a white lesion, what saliva can do over here is that we collect the salivary samples and check their profiles, right? If the profiles showcase really high levels of interleukin 6, 8, CD44, miRNA, we are headed towards, okay, yes, this lesion is very much prominent to getting into or converting into a malignancy. Let's diagnose it. Let's take the tissue biopsy. So saliva can always be an adjunct, not a comparison to the standardized tissue biopsy ever.
Okay, okay, I understand you. Thank you. Thank you, Dr. Voda Fatima. And our next poster presenter, it's Dr. Babatope Lonre Avasusi from Saudi Arabia. He will present it on topic kyphospholysis in a postmenopausal women on dialysis for chronic kidney disease. Please, Dr. Babatope.
Yeah, thank you very much. Yeah, good morning. I hope you can hear me. Hello? Hello, good morning.
Sorry, we can't see your screen now.
Yeah, can you see my
Okay.
screen now?
Yes.
Yeah, thank you
Yes.
very much. Good morning. Thank you to the organizers of the conference, my co-presenters, and all the listeners. Thank you for the opportunity and the platform to present this. I'm Dr. Babatope Larry Awoshusi. I'm an anatomical pathologist at King Khalid Hospital, Al Majma in Saudi Arabia. And today I'll be presenting the case report of calciphylaxis in a postmenopausal woman who was on dialysis for chronic kidney disease. The case report was written up by myself and one of my colleagues, Dr. Tulaparaman, who works at the King Salman Medical City in Medina, Saudi Arabia. Yeah. So I hope you can see my screen.
Yes, we can.
Yes.
Yeah. Thank you. So, yeah, but it's not moving to the next slide.
No,
By way of
we
back,
see only first.
all right,
Yes, now it's okay.
by way of background, calciphylaxis is a rare, life-threatening vasculopathy. It's also known as a calcific uremic arteriopathy or uremic gangrenal syndrome. Has a strong association with end-stage kidney disease, and clinically usually presents with skin ischemia and necrosis. It's a condition that's usually characterized by vascular calcification and thrombosis. It has a high mortality rate, up to 60 to 80% in some series. It's usually seen more commonly in females, up to 60 to 70% of cases are usually seen in females in the 50 to 70-year age range. Usually it's caused by an imbalance between usually causes an imbalance of calcium homeostasis, and usually leads to intimal proliferation, luminal narrowing that can eventually lead to thrombosis and ischemia and tissue necrosis. Predominantly affects the dermal vessels and subcutaneous adipose tissue. And the risk factors that have been predisposes people to this condition, usually, as I said, it's more common in the female sex. It's also seen more commonly in people that are obese and people that have chronic kidney disease on dialysis. Then the aim of this presentation is to report a fatal case of calciphylaxis in a 54-year-old postmenopausal woman who had morbid obesity, diabetes mellitus, and chronic kidney disease. She presented with painful edema in the lower limbs and the abdomen, and further evaluation revealed that she had metabolic acidosis and elevated creatinine. So at presentation, the initial clinical impression was that of diabetes mellitus with chronic kidney disease. Then she also had these multiple ulcers on the lower abdomen and on the lower limbs. So there was also an impression of cellulitis with differential diagnosis of necrotizing fasciitis. She also developed sepsis. During the course of the treatment, her condition gradually progressively deteriorated despite adequate treatment, including antibiotics, adequate wound care, and analgesia. And despite the fact that our risk factors was also adequately managed, she eventually developed poor wound healing. And then biopsy of the skin ulcers on the lower abdomen was taken for further evaluation and was submitted to the histopathology department. What was found, the histopathological findings include calcification of vessel walls, as we can see in the first photomicrograph. It affected the arterioles and the capillaries of the dermal and subcutaneous blood vessels. There was also luminal thrombosis and also some fat necrosis with a panicolitis like pattern and associated inflammation, which are the classical histopathological findings seen in these conditions. Then the clinical differential diagnosis that was entertained includes cutaneous vasculitis, warfarin-induced skin necrosis, cholesterol embolization, and infective necrotizing fasciitis. So after treatments. The outcome of the patient was that she developed disseminated intravascular coagulation, severe thrombocytopenia, and eventually she had acute respiratory distress syndrome, and she died after 1 month of hospital admission. The take-home messages from this case report is to highlight this rare condition and to always maintain a high suspicion in patients with diabetes mellitus and chronic kidney disease with necrotic skin lesions. And also to highlight that skin biopsy and histopathology is essential for diagnosis, and to also note that this condition actually quite mimics infection, skin infection like cellulitis and necrotizing fasciitis, which usually delays the diagnosis and adequate treatments. So early recognition may actually improve the outcomes. And the treatment includes wound care, analgesia, stabilizing acute and active disease, and managing all the underlying risk factors. I also like to highlight the common risk factors that predisposes people to this condition, and it includes warfarin, other apart from diabetes mellitus and end-stage renal disease as that I've highlighted. Other risk factors include warfarin use, hyperparathyroidism, vitamin D therapy, and some rheumatological diseases. Also, generally it presents like painful nodules, plaques, and purpura, which can progress to eschars and skin ischemia, skin ulcers. So early recognition may actually improve outcomes. So thank you for listening. These are my references. Thank you very much.
Thank you, Dr. Babatope, for your informative and practical presentation. Does anyone have any question? Okay, I have a question. How
All
does
right.
postmenopausal status influence the risk of progression of the disease?
Thank you very much for the question. As I said, one of the pathogenesis actually is seen more commonly in females, usually in the 50 to 70 age group. And also, one of the main pathogenetic mechanisms is an imbalance of calcium and phosphate metabolism. So our postmenopausal status, actually, it's been known that in females, because of decreased estrogen in the postmenopausal phase, they are predisposed to osteoporosis and reduced calcium mineralization in the bones. So these sort of calcium imbalance in the calcium phosphate homeostasis in the postmenopausal age group can also be one of the predisposing factors in that age group of females. Probably one of the reasons why it's more common in females in that age group. That could explain that. Yeah.
Thank you.
Yeah,
And can
thank
I
you for
ask
the
you
question.
one more question?
Yeah.
Yeah. How is kyphophylaxis diagnosed in dialysis patients?
Usually, the commonly it could be diagnosed through radiology. Apart from the clinical
Right.
suspicion, the first thing is having a high index of clinical suspicion when they develop skin ulcers or panicolitis. So that's the first diagnostic approach. The second level is radiology. It could also plain radiograph can be used. Then some also use CT scans or nuclear medicine to map out to be seen as calcification, linear calcifications in those areas where it's affected. Usually it affects the subcutaneous blood vessels, the small blood vessels, arterioles, or capillaries in the dermal or subcutaneous areas of the areas of affectation. So apart from the clinical diagnosis, it could be diagnosed using a radiological approach. Then eventually, if we could not be diagnosed using these first two approaches, then the skin biopsy is the gold standard. Skin biopsy for histopathological analysis. That could be the end, the last results.
Okay. Thank you. It's very practical.
Thank you very much.
Thank you, Dr. Babatopa. And our next poster presenter, Dr. Akanksha Padni, Department of Pathology, Hating Institute of Medical Science. She will present a rare case of placental chorioangioma with no fetal cardiac complications. Please, Dr. Akanksha, sorry if I say not good way your name. I can hear Dr. Akasha. Are you here?
No voice. Not hearing.
Yes, we can hear. Hear. Sorry, I think it's technical problems.
Maybe next one.
Dr. Akanksha, we see your scene, but we can't hear you.
maybe have some technical problem.
Maybe I ask her. I write to her.
Okay.
We need to waiting for her a little time. Sorry.
Not available, not audible. She write it there. Is my voice audible? No.
I hear you very well. I think it's a problem with Dr. Akansha because we can't hear only her. Sorry, we have some technical problem, and we will take a coffee break now for 20 minutes.
Ma'am, Mrs. Maria, maybe we continue on our presentation. That time she also solved her problem.
Yes, but it's I can't decide this problem. We now we need to have a coffee break for 20 minutes. Thank
For
you.
20 minutes. Okay. Then we started because we are
After
ready
20
to
minutes.
present.
Yeah,
Okay.
yeah.
20 minutes. 20 minutes.
Thank you.
Don't have na mat chala. Just हाँ मैम am I audible? Yes, you're audible. I'll go from here. One second.
Mrs. Akasha, you may contact the chairman. Maybe we continue due to schedule.
So should I be continuing with my talk, or should I wait?
We decide that you're not ready, and we can continue after break.
Hello.
Hello, are you ready?
Yeah. Will I go to slide?
Next slide.
We continue.
Can we continue? Are you ready, Dr. Akaksha? Maybe we can. We decide to have a coffee break. Can we? Can we
I'm
start
ready.
after coffee break? Akanksha, Dr. Akanksha,
Yeah, sure.
can we start after
do it,
coffee
yeah.
after coffee break? Okay, after 20 minutes.
Yes. We will start after the coffee break. Yeah.
Yeah,
Thank you.
thank you. Thank you.
You should not connect to the device. See your voice is उसका साउंड पूरा बंद करो. हेलो ये ओपन है, ये बंद कर दिया. ओके ठीक है. So you can keep it beside the voice will go for this. It's working there, right? It's working. इसमें क्या दिख रहा है? नहीं होगा ना, इससे दो डिफरेंस लगाएंगे. Actually, much first meet for Amrita sir, I will sir, they will not let me talk on it. Okay. So what do you want me to do? It is working. Ah. Hello. Hello.
Yes, we are here. We are listening to you. We are waiting you.
Hello.
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 Good afternoon. We listen you. We're hearing you. 20 minutes is completed.
Dear colleague, we start after coffee break after 10 minutes.
Okay, we
Thank
waiting
you
for
for
10 minutes.
understanding. Okay. Dear colleague, after the coffee break, our next poster presenter, Dr. Akanksha Padney, Department of Pathology, Haiti, Hetutad Institute of Medical Science. She will present it on a rare case of placental chorioangioma. There's no fetal cardiac complications. Dr. Akanksha, are you here?
Yeah. Good afternoon, ma'am. Can you hear me now?
Yes.
Yes. So, a very good afternoon to all the chairpersons, speakers, and my dear audience. My sincere thanks to the organizing team for conducting such a wonderful, event through the online platform. It is my privilege to talk on this rare case in the international platform. I, along with my team are going to have done this study and going to present this case. So here I present a rare case of placental chorangioma with no fetal complications from Varanasi, India. So to start with, chorangiomas are the most common benign tumors of the placenta with an incidence of 0.2 to 0.6. It was first described by Clark in the year 1978. On ultrasound, they appear as a well-circumscribed, rounded, predominantly hypoechoic lesion near the chorionic surface, protruding into the amniotic cavity. Because of the resemblance of the tumor's components to the blood vessels and stroma of the villi, the term chorangioma was considered. These benign tumors are discrete masses composed of multiple fetal capillaries, have different in size and vascularity, correlate with the volume of the fetal blood shunted to the mass, and is of prognostic importance of fetal outcome. Most of the cases are small and asymptomatic. We have also reported cases like larger tumors. The size is more than 4 centimeter, may be associated with significant AV shunting within the placenta and leading to the complications like fetal anemia, cardiac failure, and hydrocephalus. The platelet sequestration and erythrocyte damage within the mass leads to microangiopathic anemia and thrombocytopenia. The major complication also includes is polyhydramnios and along with decrease or increase in the fetal urine output with a hyperdynamic cardiac state. So cholangiomas are vascular proliferations, usually located within a single villus structure, account for 1% of term placentas, are more common in multiple gestations and typically found near the chorionic plate. Grossly, they often appear as glassy, myxoid, and red-brown oval masses in the placenta. Counseling of the patients and relatives was done after the diagnosis. The plan of conservative management was explained to the patient and her family. The inherent fetal and maternal risks due to chorangioma were explained to them. Rarity of this tumor prompted us to report this case. So here we report a case of a young primate literate patient from a good socioeconomic background comes to us at the 8 weeks of amenorrhea. They were non-consanguineous marriage, pregnancy was confirmed, and folate supplementation was started immediately. Ultrasound confirmed viable pregnancy, after which the further blood investigations were carried out and was found to be normal. At 12 weeks, the NT scan was done. The placenta appears to be normal and was placed anteriorly at the upper segment. Anomaly scan was done at the 21 weeks of gestation, found to be a single fetus with no obvious anomaly, with a well-defined circumscribed hypoechoic lesion towards the amniotic surface. There was active blood flow. The tumor was arising seen near the chorionic plate, the cord insertion site, and the feature was suggestive of chorangioma. At 32 to 34 weeks, on the close follow-up, the patient came for etc. So the ultrasound size, on the ultrasound, this was of size 4 into 5 into 2 centimeter within increased vascularity and turgid vessels. So when we did the ultrasound later, the LSCS was performed and it was uneventful. The patient was taken for LSCS under the spinal anesthesia and the baby was delivered under the cephalic presentation and the placenta and the cord was further sent for the sampling. The placenta with the chorangioma alongside is expelled spontaneously. There was no postpartum hemorrhage or any fetal uterine insertion. The LSCS was completed uneventfully, right? The placenta was seen measuring 16 into 16 into 8 centimeter with along with a polypoidal mass which was measuring 4 into 3 into 6 centimeter on the fetal plate. Away from the umbilical cord insertion, almost approximately 10 centimeter. The placenta was weighed and it was around 835 grams. Rest of the placenta, membrane, and the umbilical cord, the maternal surface appears unremarkable. So when we did the cut surface, the mass was gray, reddish, solid with the large cystic areas. Section was taken from the placenta, the chorionic villi, along with the areas of calcification. The section was also taken from this polypoidal mass, where the next consecutive, I can show you, this is the gross image. We received this placenta, which shows a polypoidal mass lesion on the fetal surface near the umbilical cord insertion, where you can see the maternal surface and the membranes and the umbilical cords were unremarkable grossly. When we cut open the mass, it was red, glassy, brown, solid, and there were few cystic areas as well. So coming to the microscopy, on microscopy, as we can see in the scanner view, there is a 4H view. We can see a chorangioma with lakes of blood vessels, suggestive of angiomatous patterns. That's why the other term for this is given is the hemangioma or hemangioma of the placenta. And it is a non-trophoblastic tumor. So when we went into the higher power, we can see there is a capillary vascular proliferations, but we can see the proliferative endothelial cells have a cytologically bland appearance. So we differentiate this from any other conditions like a malignant conditions. The list of other associated and the differential diagnosis would rule out like chorangiosis, chorangiomatosis, as well as myoma, or sometimes even a large blood clot a long-standing can resemble this. So coming to my discussion, the ultrasound diagnosis of chorangioma is based on imaging of a well-circumscribed, round, predominantly hypoechoic mass, often near the cord insertion along with the fetal surface of the placenta. They are known to protrude into the amniotic cavity. There was no definitive etiology or positive reason has been reported. There's something called giant chorangioma, which are usually more than 4 centimeter, and it is mostly often associated with the complications like, as I discussed, AV shunting, there can be polyhydramnios, there can be cardiac failure, and microangiopathic anemia. So they can be managed conservatively if the size is of less than 4 centimeter. If the size is of more than 4 centimeter, like in the giant chorangioma, we should have a very close follow-up and look to rule out the complication and early detection. So injection of toxic substances for the treatment of chorangioma, the risk of potential exposure to which one fetal death has been attributed. Laser photocoagulation can be performed either fetoscopically or using an ultrasound-guided interstitial laser coagulation. As this case was managed conservatively because the size was less than 4 centimeter, because even though the expertise to the imaging and the obstetric radiological intervention was available, intervention chorangioma had not been attempted by the clinician earlier. Association of this condition with the preeclampsia and high altitude pregnancy suggests that the decreased oxygen tension, that is nothing but hypoxia, may apply to their development. Although the majority of chorangiomas are of no clinical significance, various complications have been reported, and these are directly related to the size of the lesion, if it's more than 4 or less than 4. Hydramnios and premature delivery are the most common significant, followed by the fetal cardiomegaly. Congestive cardiac failure and hydrops fetalis have been attributed to the increased workload in shunting blood through a large chorangiomas. When significant amount of bloods are directed through the chorangioma away from the functional villi, chorionic hypoxia may lead to intrauterine growth retardation. Complications including fetal maternal hemorrhage, fetal anemia, and thrombocytopenia reflect the sequestration of destruction of the cellular elements as they transverse the chorangioma. Skin angioma has been reported in few babies with the placental chorangiomas. So coming to the conclusion, this case signifies the importance of histopathological examination. To effectively handle the complication, it should be picked up early. Regular monitoring the patient of by serial ultrasound, surveillance by the color Doppler, and fetal echocardiography is highly recommended. Placental morphology detected should be examined and suspicious of lesion should be confirmed histologically. These are my references. Thank you.
Thank you, Dr. Akansha. Does anyone have any question? Okay, can I ask you some question?
Yeah, surely, ma'am.
Why did this case not lead to the fatal cardiac complications?
Yes, the first thing, the lesion was less than 4 centimeter. The patient's continuous antenatal and the follow-up anti-scan and all the scans were done. So radiologically, the lesion was, since it was small and it was detected early, the operative measurement was taken at the time and the conservative management was done. Everything was informed to the patient and it was operating at the right time. So there was no associated cardiac complications or any other complications, and it was very uneventful.
Okay. And can I ask you one more question?
Yes, sure.
How should be such cases be monitored and managed?
Yeah, so the main thing is antenatal scanning is very much important time to time. The second thing comes is your color Doppler. The role of the color Doppler is very important because you can rule out, you can see the vascular flow, right? So if there's an increase in the vascularity and all, we can take an impromptu action. You should look for AV shunting if there's any AV shunting. If there is, like destruction or associated anomalies because of this increased vascularity. So the color Doppler is very important. Along with that, we can do the fetoscopy, like I said, and a continuous monitoring, like continuous close follow-up to be done.
Okay, very interesting. Thank you. Dear colleagues, Dr. José Manuel Serva Grau will not be able to present due to health issues. Now we'll be sharing his presentation slides.
It's not hearing, no listening.
Because doctor has a health problem and can't to present his presentation. We share only his presentation. You can read and because he can't
Okay, no
to go
problem.
to
Okay.
join us. Dear colleagues, we continue. Thank you, Dr. Jose Manuel Serva Grau, for sharing us the presentation. And our next poster presenter, Dr. Sabrina Suleiman, current resident doctor, Leighton Hospital, UK. She will present it on an interesting case of amyloidosis of the lymph node, a case report and review of the literature. Please, Dr. Sabrina, are you here?
Yes, can you hear me?
Yes.
And can you see my screen?
Yes.
Perfect. Okay. Thank you, Maria, for the introduction, and thank you for having me here. Thank you to the people who've organized it. It's a really good conference so far. As said before, I'm Sabrina, an F2 in Leighton Hospital in the UK, and I'm doing my talk on a case report, an interesting case of amyloidosis notified in the lymph node. And a special thanks to Dr. Gamaj and Dr. Farua, who helped me with producing this case report. I think Dr. Farua is in this conference, but she's currently in a meeting, so she might join later on. So yes, so basically we'll talk through a brief overview of what amyloidosis is and a bit about the pathophysiology, and then we'll talk about the case report itself and the slides and a bit of discussion. So as you know, amyloidosis is extracellular deposition of misfolded amyloid proteins, and this eventually leads to organ dysfunction and failure. And presentation with lymphadenopathy is not common, which we will see in this case report. And so often to suspect amyloidosis, you should have a high degree of suspicion. And as said before, it's a rare condition, so the incidence rate is quite low with 5.1 per million per person. And this was taken from the United States. But currently, it's becoming more prevalent, and I think it's because of the fact that we are more aware of how it presents and we're better with diagnosing it. So again, it's a multi-system disease, and there's misfolding of proteins into highly organized insoluble amyloid fibrils, and they deposit into the tissues. Early recognition is really important because without it, it can lead to organ failure and death. It's not reversible. And often it presents with organ involvements of the kidneys, the heart, the nerves, and soft tissues. There are four main types of systemic amyloidosis. The main one we will focus on with this presentation is AL, which is the light chain amyloidosis, but you also have AA, hereditary, and senile systemic. So AL amyloidosis is associated with plasma cell dyscrasia, and it's often associated with myeloma, and it's the most dangerous one, and it can progress quite rapidly. And then AA is associated with chronic inflammation, so we suspect this in patients who've got a background history of rheumatoid arthritis or chronic Crohn's disease. Hereditary is also quite rare, and often it's based on suspicion from family history. And senile systemic amyloidosis, there's not a lot on this, but they mentioned that it's associated with cardiac dysfunction. So often they can present with heart failure, and often treatment is treating it as if it is heart failure, so diuretics and ACE inhibitors. So a brief overview of the pathophysiology. I found this diagram which is really useful because it kind of splits up the three main ways that the protein kind of gets built up in the body. So you've got the abnormal and excess production of normal proteins which build up and they lead to amyloidosis, or it's normal protein which doesn't get metabolized properly, so then it just builds up, or it's production of mutant proteins in the normal amount, and that cannot be degraded or aggregated. So the main one that we'll focus on is the AL, the amyloid light chain, and you can see here it's the plasma cell tumors, and it's the antibodies, the chain itself, the light chains are not appropriately formed, so they build up and do not function as well. So moving on to our case report itself. So it's a 74-year-old female who she presented to the upper GI clinic with complaints of reduced appetite and altered taste. So again, it's non-specific symptoms. But the thing that caused alarm bells was the significant past medical history of right mastectomy, which caused her due to her previous breast carcinoma. So this raised suspicion for metastasis, and therefore imaging was requested. And here we request a CT thorax, abdo, and pelvis to identify if there's any signs of metastasis. And it showed widespread lymphadenopathy and was single adrenal lesion. And she was discussing breast MDT, and they decided it was appropriate for biopsy sampling. First of all, they took an axillary biopsy, and this was reported as reactive changes. And they took another sample through the EBUS because she's got widespread lymphadenopathy, and it was noted in this one that there was some suspicion of deposits, which we will talk through. So a Congo red staining was applied, and that was positive, and then it was examined under the polarized light, which showed the amyloid deposits through the appearance of apple green birefringence. And based on that, she was rediscussed in MDT, and she was referred to hematology and started on the appropriate chemotherapy. I've attached the slides in the next slides, which shows the process of the staining and the method to identify the amyloidosis. So here you can see there's two slides. It's of the lymph node biopsy, the one that was taken from the EBUS. And you can see on the right, it's the low, and then on the left, it's the high resolution. And you can see the smooth areas, which are the amorphous eosinophilic hyaline deposits, which make you suspicious amyloidosis. And then around it, you can see giant multinucleated cells. I don't know if you can see it quite clearly, but in the one on the left, you can see it next to the smooth area there. So based on that, this raised suspicion by the histopathology department, and they did a Congo red stain, and you can see this positive stain which showed the pinkish amyloid deposits, and it's the streaky bit here. And again, this is the low and this is the high. And then to confirm it off, we put it under polarized light, and you can see the shiny bits here. That is the apple green birefringence, which confirms the amyloidosis. So this was, again, as we said, it was discussed in MDT and confirmed amyloidosis. So why have we picked this case? With amyloidosis, you can have clinical suspicion, but in the end, it's a tissue biopsy, which is the diagnosis. Due to the way that it works, and due to the deposition of the non-blanching amyloid fibrils. And that is the reason why you get this apple green birefringence under the polarized light. So it's quite interesting to see. And as we mentioned before, lymphadenopathy is an uncommon manifestation of amyloidosis. So often you see patients presenting with renal problems, abdo problems, or cardiac dysfunction. So the fact that someone presented with lymphadenopathy is quite rare. And in a retrospective case study analysis that was done over a couple of years, and there was 3,000 patients who had amyloidosis that were collected. And it was noted only 47 presented with lymphadenopathy. So it's quite rare, and there's still a bit of research, and I think this case report kind of highlights that you should have this as a differential if it isn't metastasis. So here I've written that the patient's history of breast carcinoma complicated the clinical picture because we assumed it was metastatic disease, which rightly so, when you see a patient with lymphadenopathy. But on further explanation and of tissue biopsy, we were able to confirm it wasn't. And then based on this, we were able to start the patient on treatment, and there's a specific chemotherapy regime for patients with AL and multiple myeloma. So it's typically cyclophosphamide and dexamethasone with bortezomib, and this reduces the cloning of the amyloid-free light chains, and it reduces the production of them, so there's a higher chance for improvement in organ function and survival. And then in terms of limitations of this case report, obviously we looked at it from the tissue side, not the patient, so we weren't able to speak to the patient directly. So identification or further investigations that were done are not very clear, but based on research of amyloidosis, there is an assumption that the necessary blood tests were done, and especially for staging as well, and for staging amyloidosis. So in conclusion, amyloidosis clinically can mimic metastatic malignancy, and it should be as a possible differential to have in the back of your mind. And obviously, tissue diagnosis is essential, and use of staining is critical for specifying the cause. And as always, early recognition always improves prognosis, as we can see in this. It won't reverse the disease, but it can help to improve the survival and the prognosis. Thank you for listening. Any questions?
Thank you, Dr. Sabrina. Somebody have a question? Does any question have any question? Okay, can I ask you some question?
Yes.
How can lymph node amyloidosis be differentiated from other lymphadenopathy?
So as mentioned in the slides, thank you for your question. It's amyloidosis, obviously you can suspect it clinically, but in the end, it's all to do with the tissue biopsy. So when we went through the H&E staining and identified the deposits, that led to the suspicion of amyloidosis. And then if it was normal lymphadenopathy, it wouldn't turn positive on the Congo red stain, and it wouldn't show the apple pie fringence.
Okay, thank you. And how does this case compare with previously reported cases in the literature?
It's on review of the different articles that were written previously, it's very rare. I think there was, as mentioned before, only when they did the retrospective study, they found there was only 47, and these patients weren't people with background of cancer. So when they found out that they had this lymphadenopathy widespread with no source of primary, they went straight away to do the biopsy and suspected amyloidosis. Whereas in this patient here, we suspected metastatic, which might have just prolonged the identification of the disease. So it's still very rare, and I think by having these case reports, you're able to recognize perhaps it is a differential.
Thank you for this interesting case.
Thank you.
Thank you, Dr. Thank you, Dr. Sabrina, for your interesting presentation. We are pleasure to invite our next poster presenter. It's our dear colleague from Azerbaijan, Alibayeva Agun Alimar, Assistant Professor of Department of Cytology. Is it my colleague? Cytopathologist, embryology and histology of Azerbaijan Medical University. She will present it on characterization of crosstalk between macrophage migration inhibitor factor and T cells. Please, Dr. Agun.
Just 1 minute. It's visible?
Yes, we see the screen very well and hear you very well. Thank you.
Okay. First, I want to hello everyone, and with your permission, dear chairman of conference and participant of this conference, I would like to present my presentation on topic characterization of the crosstalk between macrophage migration inhibitor factor and T cells. It means T lymphocyte. I can't see, just 1 minute. It's visible or no?
It's visible, but we see only first slide.
Okay, just
On
1
the
minute.
yeah.
I close it again. Mhm.
Can you try to change your slide?
Just 1 minute. I stop it and again I share it with you.
Okay, okay.
Is it visible?
Yeah, it's visible, but can you
First
open the
only.
presentation? Yes.
Now?
Now we see
Okay, now
second
we
slide.
started.
Yeah.
Okay, first I
Yeah.
want to
Yeah.
talk about macrophage migration inhibitor factor because that factor is inflammatory cytokine that occupy a central regulatory position within pulmonary immunity and implicated in driving aggressive systemic inflammation. MIF can have a dual function. It acts as protective in host immune response and in some cases exacerbating to host injury. MIF may enhance the activation of immunocompetent cells, especially T lymphocyte, B lymphocyte, macrophage, and facilitated the release of pro-inflammatory cytokines, which contributing to the efficient clearance of invading pathogens. In chronic, it has been implicated in the pathogenesis of the different respiratory diseases such as asthma, cystic fibrosis, respiratory distress syndrome, or acute inflammation. The object of the study, aim of this study was to evaluate, compare, and study the dynamics of structural quantitative change of T cells in the lung tissue after a single dose intravascular administration of macrophage migration inhibitor factor, which is a gain from the company protein specialist with catalog number 193 from Israel NACE zone. Next material for this research where is lung tissue that is purchased from 84 adult male Vistar albino rats that is obtained from Scientific Research Center of Azerbaijan Medical University. Animals with growing and kept in pathogen-free condition in the vivarium of the same center, and there is regulated always the temperature, humidity, as the regularly light dark cycle with free access to food and water. All laboratory works is conducted under the European Union Directive on the protection of animals used in scientific research and other applicable ethical standards and guidelines when handling laboratory animals. The experimental animals divided into 3 groups. Intact group, which is in number 12 without any intervention. Second one is comparison group in number 24 that administered intravascularly 0.3 milliliter physiological solution. And third group that is a main group in number 48, which is a macrophage migration inhibitor factor in amount 1.39 microgram is dissolved in the physiological solution. It's also administered to this group. And this both group, saline injection and macrophage migration inhibitor injection, animals subdivided into subgroups, into 6 subgroups, depend on the extruded these animals from the experiment. 2 hour, 2 day, 3 days, 7 day, 15 day, 30 days. And during the experimental period, no rats died in any group by the administration of the macrophage migration inhibitor factor induced inflammatory response. Next, we talk about lung tissue, which is obtained from experimental animals. They are for histological analysis fixed in the formaldehyde, embedded into paraffin blocks, then serially sectioned in microtome. General morphological evaluation was conducted with the assistance of hematoxylin eosin staining. For detection immunocompetent cells, we use CD3 for the tail lineage cells, CD20 for the B lineage cells, CD68 for dendritic cells or macrophage, and then serial section, it's in thickness 3-4 micrometer. It's sectioned from paraffin blocks. For detection, we use appropriate monoclonal antibody. And in addition, for proliferative activity of the cells controlling for the revealing, we evaluated with key 67 monoclonal antibodies. That slide. Immunocompetent cells were identified by histological, immunohistochemical criteria, morphometric parameters analyzed by variance and non-parametric statistical analysis methods. The first, I want to tell, the lung is an organ which constantly, without any barrier, exposed to external environmental influences, especially microbes, bacteria, dust particles, tobacco, hazardous substance. And that's why it's important to study the distribution and types of immunocompetent cells in the lungs, which they perform the protective and defensive function of the organ. Macrophage migration inhibitor factor and immunocompetent cells interaction can be important in planning and in the treatment methods of immune pathological processes, which is gained by pathogens which conform their intensity. If we talk about immunocompetent cells, that included lymphocyte in T and B lineage cells, antigen-presenting cells, dendritic cells, macrophage, granulocyte, eosinophils, basophils, and mast cells. But in that case, in this we mostly we focused on T cells. Generally, we observed that immunocompetent cells in the lung tissue, which is located histotopographically in two main locations. One of them, it's named lymphoid collection. That lymphoid collection is composing 89.1% of all lymphoid immunocompetent cells, 10.9% that is included free cells, which they have ability to migration. That lymphoid collection, which the most amount of composing, it's also by their location subdivided into three parts. One of them, the most largely, the percent, which is a 62.3%. That is a named bronch-associated lymphoid tissue, which is accompanied of all bronchial tissue. Second one, 7.7% lymphoid tissue. It's named perivascular lymphoid tissue. It's accompanied by the all vessels which are present in the lung tissue. And the small amount, 9.1%, that is a named intraorganic lymphoid cluster. That lymphoid tissue, which is a named lymphoid collection, within that lymphoid tissue is absent follicular reactive center in the lymphoid cluster, intermediate and peripheral zone, which is a maybe of one manifestation of the difference between this structure and lymph nodes that is located in the gate of the organs. The second one, by the composition of lymphoid collection, there are present three type immunocompetent cells is revealed. One of them, the most volume, is occupied by B cells, 77.2%. The T cells, which important to know for us, is 7.6%, and the small amount, that 5.2%, that is included antigen presenting cells, which is included dendritic cells, macrophage. And histologically, which is detected by immunohistochemical reaction, B cells in the lymphoid collection, central part is occupied by the B cells, it's detected by CD20. T cells located peripherally, and it's detected by CD3 plus. And the third one, dendritic cells, which is also present in the lymphoid collection, that is a dendritic interdigitating or macrophage, mostly by the CD68 detected. It's located singly, but it's located in the mixed zone within the T and within the B lymphocyte. Ultrastructurally, in the bronch-associated lymphoid tissue, on the perivascular lymphoid tissue, are present that lymphoid collection, and within the lymphoid collection, very clearly visible plasmatic cells, lymphocyte, dendritic cells, fibroblasts in perivascular lymphoid tissue, differentiated plasmatic cells, macrophage, dendritic cells also are visible. That is a like signal ultrastructurally, which is we can say that antigen independent differentiation of lymphocyte, which is occurring within that antigen presenting cells. The second part that is named free cells. Free cells in 10%, 10.9% from all immunocompetent cells. It's also by the composition, it's subdivided into three types, that free cells unevenly distributed throughout the organ and no have specific topographical feature. These cells have the ability to migrate it within the organ during different acute inflammation or chronic inflammation and prepare immediately immune response. And that 42% it composite of from antigen presenting cells, which is included there, macrophage, all macrophage, including alveolar macrophage also. And this is related to the different course and mechanism of antigen neutralization reaction in the lung stroma and respiratory parenchyma. That 38.6% is composed of from B lymphocyte, and the small amount is composing of from T lymphocyte, 19.4%. Next slide showing to us is detection by immunohistochemical reaction B cells at the perineural localization around the alveoli and small vessels, which detected by CD20. The T cells detection by the CD3 monoclonal antibodies, which is also located peri-alveolar interstitial tissue in the stromal septa and around the small arteries. And in the CD68 positive cells, it means macrophage and dendritic cells, are detected in the wall and in the lumen of the small bronchi, as well as in the aerohepatic barrier and alveolar floor and lumen. After administration of the macrophage migration inhibitor factor on the third days of the experiment, reaction with immunohistochemical reaction with CD3 monoclonal antibody, they're showing here, there is increase in the number T lymphocyte in the lumen of the bronchi, in the alveoli, and it's detected by red arrow they're showing. It's morphological evidence which is have direct influencing on T cells element of the macrophage migration inhibitor factor. On day 7 also it's visible in which detected CD3 monoclonal with immunohistochemical reaction with CD3 monoclonal antibodies, T lymphocyte increase in number. Then we prepared its dynamic change of tail lineage cells intact, as we see. It's the in the lymphoid collection in the free cells. Free cells is little more, but in the lymphoid collection it's the less in number. But after 2 hours, it's insignificant increase is shown for CD3 plus cells. And continued on the second day. Highest level, it's visible on 3rd and 7 days after MIF injection, which they compared with the intact animals and placebo groups. And the number of the CD3 plus cells decreased slightly on day 15 and 30 after MIF administration. But it's also statistically is higher than the indicators in the intact and placebo groups. It may serve as a complex morphological morphometric conformation of the T-inducible effect of MIF and serve as morphological evidence of the direct involvement of T cells in the reception of exantigens. In conclusion, summarizing the data on distribution and quantitative analysis of immunocompetent cells, especially T lymphocyte, it should be noted that the lungs are rich in lymphoid tissue. It also active participant organ in immune responses to environmental antigens. Also, exogenous macrophage migration inhibitor factor induced tail lineage cells in the lung of Wistar albino in phased asynchronous manner. Thanks you for your attention and for your patience, and I am so happy to present my presentation in like that pathology conference, which participated all participants and chair of this conference.
Thank you, Dr. Agun. I thank you for your excellent presentation. I was in Azerbaijan last year, and I very happy that participants from Azerbaijan to be here.
Thanks.
Does anyone some question? Okay, can I clarify some information? Ask you some question? Oh, thank you. How does this interaction impact immune response of disease progression?
On T cells, on T
Yeah,
lymphocyte. Okay, that macrophage migration inhibitor factor, that inflammatory cytokine, you have, as we say, it's directly prepared body for inflammation. Macrophage migration inhibitor factor. It's also act on T cells. T cells also prepare immune response, and directly it's acted on T cells without any doubt. And that's why on from second day, it started to increase in number. That highest level on third 7 days, when that immune response is ready and number of the T lymphocyte increased by its proliferation, by its differentiation. That's why it's prepared immune response. It's without any doubt.
If I understand, notice can target migration inhibitor factor improve T cells therapies? Yes.
T cells, B cells, and macrophage, dendritic cells, we observed in all these three type immunocompetent cells. From there, just we in our this abstract, in our this speaker poster presentation, we mostly focus it on the T cells, but it's attracted to B cells also, to macrophage. Macrophage, that free cells, it's inhibited. But B cells, T cells is induced to prepare immune response for the macrophage migration inhibitor factor. It like stimulated T cells to increase and prepare immune response from the body.
Okay, thank you. I got. Thank you, Dr. Aygun. And our next speaker is Dr. Gurbanova Shahana Gazanfar, assistant of Department of Cytology, Embryology, and Histology of Azerbaijan Medical University, Azerbaijan. She will present on structural organization of placental tissue in physiological pregnancy. Please, Dr.
Hello, hello everybody. I would like to appreciate the organization team and especially you, Miss Marina, for your patience and providing this conference. My topic is about the ultrastructural features of the placenta in physiological pregnancy. I would like directly to start to my presentation. Is everything visible?
Yes,
Do you
yes,
see?
we see your screen and hear you. Thank you.
Okay, I want to turn off my camera and to start. As we know, the placenta is a temporary organ that provides for the exchange of substances between the mother and fetus and has immunological and endocrine functions. The ultrastructural integrity of its tissue, particularly the syncytial trophoblast, cytotrophoblast, and villus stroma, is of crucial importance for physiological course of pregnancy. The functions performed by the placenta are based on substructure ranging in size from the centimeters to nanometers, and integrated understanding of the placenta requires that assessment of structure and function at all these scales. The anatomy of the placental tissue is more clearly studied in three-dimensional than in two-dimensional format. The three-dimensional investigation of the placenta includes magnetic resonance imaging, computed tomography, and whole mount light microscopy. Until recently, few three-dimensional imaging studies have been conducted at the ultrastructural scale. Volume electron microscopy is a new approach that provides new insights into the ultrastructure of the placenta. Electron microscopy has been used to study the placenta since the 1950s, which allows the detailed ultrastructural characterization of the placenta. Both transmission electron microscopy, which measures electrons transmitted through ultra-thin tissue sections, it's about 70-100 nanometer, and the scanning electron microscopy, which measures the backscattering of the electrons from the sample surface, have been used to study the placenta. Imaging of the placenta using electron microscopy, mainly transmission electron microscopy, made it possible to identify and characterize placental features that are difficult to detect with light microscopy, including microvilli and mitochondria, which are now considered common structures. In this study, the ultrastructural characteristics of the placenta formed in health pregnancies were investigated. For study, tissue samples were selected from placentas obtained from 20 women who had healthy pregnancies immediately after natural birth. The obtained placental fragments were fixed in solution containing 2% glutarialdehyde and paraformaldehyde and 0.5% picric acid prepared in phosphate buffer in order to study them at the ultrastructural level using electron microscopic research method. After post-fixation in a 1% osmium acid solution prepared in phosphate buffer for 2 hours, the samples were dehydrated sequentially in 50, 78, and 90% ethanol solutions for 30 minutes each, and then 90% and 100% ethanol solutions for 1 hour each. Dehydrated pieces were embedded in spore resin and molded into the blocks. From the prepared blocks, semi-thin and ultra-thin sections were produced using an ultra microtome. To study the placenta at the ultrastructural level, the semi-thin sections obtained from the blocks were stained with a 0.5% methylene blue solutions. The prepared placental pieces were attached to a glass slide, and 1 drop of 1% sodium borate solution and the equal amount of the 1% methylene blue solution were added into the semi-thin sections. After passing them several times over the spirit lamp, the pieces were stained. After the stained preparation were washed with distilled water and completely dried, 1 or 2 drops of ethylene were added. The preparations were then covered with a cover glass and examined using light microscope. The method proposed by FDA and MICO was used to identify different structures of the placental tissue. For this purpose, the semi-thin sections were first stained with methylene blue according to the protocol described above, then stained with a 1% azure 2 solutions, followed by 0.1 alkaline fuchsin dissolved in 5% 1% ethyl alcohol. The semi-thin sections stained with methylene blue and the amico methods were examined using the microscope from the Germany. Micrographs of the required area were taken under various magnification using the digital Pixera camera manufactured in the USA. The ultra-thin golden sections were first stained with 2% uranyl acetate solution and then with 0.5% pure lead citrate prepared in the sodium hydroxide solution. The ultra-thin sections were examined under the transmission electron microscope at voltage 120 kilowatt, and micrographs were obtained. Then all at the ultrastructural level, the following main structures were observed. In situ trophoblast cells, a rich presence of microvilli, numerous mitochondria with early visible crista, and endoplasmic reticulum, represented by dilated cisterna, were observed. The cell nuclei were oval in shape with peripheral accumulation of chromatin, intercellular contacts were preserved, and the cell membrane were intact. No degenerative changes or pathological vascularization were detected. Here we have pictures which was taken by the electron microscopic ultra-thin pictures here. As you see, here you see thin cytotrophoblastic structures with multinucleates. Here at the periphery, the heterochromatin. Here we may see the exosomal vesicles that shows activity of this structure. And inside, we can see collagen fibers, the stroma of the placenta, and they are very thin, reticular fiber also. And here endothelial, the capillaries with thin endothelial cells inside, there are erythrocytes. In other picture, this is semi-thin section of the placenta piece. We see rich blood capillaries, which is located superficially, and thin endothelial lining cells inside erythrocytes, and between the capillaries, the placental stroma. And here in the B picture, we also see the capillaries and with stroma, with sensitive trophoblastic nucleus, endothelial cells with other structures. In this picture, again, semi-thin and ultra-thin pictures observed here. Here in the picture B, we can see the stroma, and in this stroma between two capillaries, and here we can see cells. They are mesenchymal stem cells, which may differentiate to different type of cells, which give rise to different type of tissue. For example, osteogenic cells, chondrogenic cells, adipocytes, adipocytic tissue, and other tissues. Here again we have thin endothelial with basal lamina inside the erythrocytes. In this D picture, we can see fibroblasts, and also we can see macrophages, which is known as a Hauber cells here. Which take part in immunological processes here in placenta. Here again we see the macrophage. In the B picture we see macrophage. There are vesicles, lysosomes inside well-developed organelles. Here in picture A also the Hauber cells. around they are more around the capillaries, which take part in attaching, separating the unnecessary tissue structures from this area, placental area. Here we may see the fibroblastic cell, and here we know that they take part in producing collagens, stromal elements of the placenta, and here we may see the borders of fibroblast and nucleus and well-developed organelles inside. And here again, we see blood capillary with erythrocyte inside endothelial cell and its nucleus with macrophages, Hauber cells here. In the conclusion, at the ultrastructural level, structures in the placenta tissue form a healthy pregnancy are evaluated as a structural indicators that ensure the placenta's normal function state and effective transplacental exchange. Thank you for attention.
Thank you, Dr. Shahana, for your excellent presentation. Somebody have a question? Okay. Can I ask you one question?
Yes, of course.
How does vascular organization contribute to placental efficiency?
Placental efficiency, so how they form placenta or what?
Yeah.
Yes, thank you for your question. We know that from the gestation first forms trophoblast, which differentiates in situ and then cytosine cytotrophoblastic cells, and then mesenchymal extraembryonic mesenchyme enters inside between these structures and forms villi, and then this mesenchymal cell inside the mesenchymal tissue forms islands, which give rise to the blood vessels and blood formed elements, and then from directly trophoblast and syncytial trophoblast not forms vessels. The vessels forms from extraembryonic mesenchyme.
Okay,
and then that enters inside, forms primary villi, secondary villi, tertiary villi, and then at the end, near the end of the gestation, all these structures differentiate into the placenta. In some are well organized vascular system replace with a specific part of areas, and that forms placentar, mater placentar circulation according to this differentiation.
Okay.
So, but there is no direct contact with kind of cytotrophoblast, trophoblast, and the blood vessels. Blood vessels develops from directly mesenchymal cells, mesenchymal tissue.
Okay, thank you. Somebody have any question? No. Thank you, Dr. Shahana.
Thank you so much.
As we come to the conclusion of this conference, I would like to express my heartfelt thanks to all of distinguished speakers, poster presenters, and delegates for their invaluable contributions and active participation. I would like also to express my sincere appreciation to the organizers committee and all those working behind the scenes for their hard work and commitment. It make this conference possible. It has been a pleasure hosting such as esteemed gathering of professionals, and we hope the knowledge shared we will continue to inspire future collaboration and advancement in the field. We are pleasure and to announce our next edition, and I hope to see you next year. The Emirates Pathology, Digital Pathology Cancer Conference and Exhibition scheduled for February 1st to 2nd, 2027 at Novotel Al Barsha into Dubai. We look forward to welcoming you again, and thank you all once again for being a part of this event, and have a wonderful day ahead.